Well, good evening. I want to welcome everybody to this week's happy hour session. We're going to be looking at a variety of inflammatory and neoplastic conditions this week. As always, I'll be checking the chat from time to time. For those of you who are listening to the session live, please feel free to throw questions into the chat. If not, you can always email us at sagesdx.com. Or you can email me directly, tdavis@sagesdx.com. So without any further hesitation, let's go ahead and get started. Let me go ahead and tilt the first slide here. And our first specimen consisted of a trisected shave biopsy. And as we zoom into higher power, hopefully you all were able to discern that we're dealing with an inflammatory process here. We've got a superficial perivascular infiltrate within the papillary and double reticular dermis. And right away, you can appreciate the fact that there's epidermal hyperplasia. And so we're kind of in the psoriasiform category, which of course tends to be associated with papulosquamous conditions. The epidermis here is actually uniformly hyperplastic. And as we move down to the papillary dermis, or move down to higher power, we can see that there are some dilated vessels in the papillary dermis and quite a bit of perikeratosis that's focally confluent within the stratum corneum, and so one could begin to think about the possibility of psoriasis here. Not great thinning of the suprapapillary plates, and there is an intact granular layer, but sure enough, if we move to higher power, we can see that there are actually some neutrophils at the summits of the perikeratotic foci. So, not bad for psoriasis. However, anytime one sees neutrophils within the stratum corneum, one wants to make sure that one scrutinizes the cornified layer looking for organisms. And sure enough here, hopefully you were able to see them within the stratum corneum. There were several hyphal elements, fungal elements, some cut cross-section, some cut longitudinally. I'm going to move over a little here because in some of these areas, you could actually see that there were clearly septate hyphal elements within the stratum corneum. And so this is an example of dermatophytosis. Dermatophytosis can really mimic almost any of the patterns of skin disease that we see. And clues that really should make you take the time to look for fungal elements in the cornified layer or in the sections in general are neutrophils within the stratum corneum. Anytime one has a spongiotic dermatitis on a volar surface, palm or sole, it's a good idea to scrutinize the cornified layer for fungal elements and even get a PAS or GMS if that's available for you. Another clue, and it's kind of nicely demonstrated over on the right side of this particular piece of tissue to dermatophytosis, is the presence of a two-tone stratum corneum, the so-called sandwich sign. And if you take a look here, the sandwich sign consists of two types of stratum corneum. In this case, if you want to use the sandwich metaphor, our top piece of bread is the basket weave orthokeratosis. The bottom slice of bread, thinner, is the compact ortho. And between the two is usually where we see the hyphal elements. And you can see where my cursor is. Let me get the pencil. Some hyphal elements cut in cross-section. And the sandwich sign can be either basket weave orthokeratosis overlying compact orthokeratosis or basket weave orthokeratosis overlying perikeratosis. And then finally, the fourth clue that should prompt you to look for hyphal elements is the presence of a psoriasiform dermatitis like this with a compact cornified layer. And that variant of dermatophytosis typically is fairly pauci-inflammatory. So again, neutrophils in the stratum corneum, spongiotic dermatitis on volar skin, a two-tone stratum corneum or the sandwich sign, and a psoriasiform dermatitis with a compact cornified layer are all clues that one might be dealing with dermatophytosis. And let's go ahead and move on to case number two. Case number two was an incisional biopsy specimen. And one can see that we've got a neoplasm here that's extremely well circumscribed. It's basically a pink ball that is located in the subcutaneous tissue. And this neoplasm has a very benign silhouette. It's always good to study a neoplasm at low power and assess the overall architectural configuration and try and get a feel for whether one is dealing with a benign or malignant tumor. Certainly well circumscribed and relatively symmetric. So again, has a very benign silhouette. As we begin to move to higher power, we can see that this pink ball in the subcutaneous tissue here has areas out at the periphery that are a little more loose, probably not as cellular as those zones in the central portion of the tumor. You notice there's a little bit of a blue discoloration here, and we're seeing a lot more nuclei in this central, more tightly packed area of the neoplasm. We also have a number of dilated and congested vessels, some of them kind of partially filled with vibrant thrombi. And if we move to higher power and begin to study the cells comprising this neoplasm, we begin to see that this is a neoplasm composed largely of cells with spindle-shaped or fusiform, or blunt-ended nuclei. Some of them have been cut, they're arranged in fascicles, and some of the fascicles have been cut in cross-section. And so in those areas, the nuclei appear round. In the areas where the fascicles have been cut longitudinally, one can appreciate that these have spindled shapes. And in some areas, one can see that the nuclei comprising these cells are arranged in parallel rows with relatively acellular areas between them. And these structures, I'm going to get my pencil here, are Verricae bodies. And Verricae bodies, of course, are a histologic hallmark of Antony A tissue. And out at the periphery of this neoplasm, the more loosely located or formed tissue with spindled cells embedded in an edematous stroma, somewhat more haphazardly arranged, are zones of Antony B tissue. And of course, the combination of Antony A and Antony B tissue in a well-circumscribed round pink ball should make you think about the possibility of a schwannoma, and that's exactly what this is. Schwannomas are peripheral nerve sheath tumors, much as neurofibromas are. These are almost always located in the subcutaneous tissue, and it's important to keep in mind that these are a pretty heterogeneous group of tumors in that no two schwannomas are going to look alike. The Antony A and Antony B tissue are not uniformly distributed throughout the tumor. So the amount of each type of tissue varies from schwannoma to schwannoma, and even within a given schwannoma. So one can have at one end of the schwannoma almost all Antony B tissue, and in other areas almost all Antony A tissue, leading to the reference by some people of hard schwannomas, which are Antony A tissue, and soft, which are almost all Antony B tissue. These tumors will stain with S100 protein and SOX10. So again, this was a classic example of a schwannoma. The differential really of circumscribed pink nodules like this in the deeper tissue, particularly in the subcutaneous tissue, includes not only schwannoma. One could also think about the possibility of a pilar cyst, but pilar cysts obviously have keratin in the center, not nuclei, and they're epithelial lined. Differential would also include an angioleiomyoma, which is also a well-circumscribed tumor that tends to be located deeply. It, of course, has slit-like vessels surrounded by smooth muscle fascicles, no Verricae bodies. And then one could also think about a giant cell tumor or fibroma of tendon sheath. The former, of course, has characteristic osteoclast-like giant cells, with scallop borders sitting in lacunae. The giant cells kind of resemble big chocolate chip cookies. So again, schwannoma. Slide number 3 was a bread loaf shape biopsy specimen. And as we move to higher power, we can see that here we've got an epithelial neoplasm. It has been transected at its base. The surface of the specimen is characterized by quite a bit of hyperkeratosis, as well as papillomatosis and epidermal hyperplasia. And then within the dermis, you can see that we've got these elongated branching tubular structures and cystic spaces. And anytime you see elongated branching epithelial tubules and branching tubules in the dermis or subcutaneous tissue, in other words, in the skin, you want to think about the possibility of apocrine tumors. Apocrine tumors tend to have these elongated branching tubules. And one can see here that this proliferation actually is emanating from the undersurface of the epidermis. And a very characteristic feature of this particular tumor is the fact that we see a transition from stratified squamous epithelium to glandular epithelium. And it's kind of gradual in this area. These branching tubules have papillary projections. The papillary projections are lined by this glandular epithelium. And in areas here, one could see evidence of decapitation secretion. The cells comprising this proliferation have round to oval nuclei. There's not appreciable cytologic atypia. And another characteristic feature of this tumor is the presence of a very plasma cell rich stroma or infiltrate rather within the pores of the papillary fronds. And this is just a beautiful study here of plasma cells. You can see that these plasma cells tend to be much larger than the adjacent lymphocytes. They have more abundant cytoplasm. The nuclei tend to be located or displaced to the side of the cell. There's usually perinuclear clearing, and you can see the clock-faced chromatin pattern of these plasma cells quite nicely. So taken together, these features are diagnostic of a Syringocystadenoma papilliferum. This lesion definitely has the fjords and fronds that Elston talks about. Again, the histologic differential here would largely include this tumor, a hidradenoma papilliferum, which also has papillary projections extending into cystic spaces, and possibly even a digital papillary adenocarcinoma. All three tumors are characterized by epithelial-lined glandular structures with papillary projections. Syringocystadenoma papilliferum again shows attachment to the overlying epidermis. It's characterized by papillary fronds that have a plasma cell-rich infiltrate. The other two tumors are not. And again, you'll see that attachment to the overlying epidermis. A hidradenoma papilliferum is also characterized by the papillary projections in cystic spaces. It has a maze-like configuration, tends to be located deeper in the dermis, and the stroma is non-inflammatory. And then finally, digital papillary adenocarcinomas are epithelial-lined papillary tumors located on the digits. So the biopsy will be from volar skin, and they tend to be characterized by a high degree of cellularity. So the glandular structures tend to be packed back to back. The degree of cytologic atypia can vary, however. Okay, let's go ahead and move on to our next case. This would be case number 4. And the specimen in this case was an excisional biopsy specimen. I'm going to tilt the slide here. And one can see quite a bit of fat. And hopefully you noticed pretty quickly as you went to higher power that the epidermis here was somewhat thinned with effacement of the reedy ridge pattern. And there was this horizontal zone of fibrosis present in the central portion of the specimen. Within the dermis in this zone, there's a fairly dense infiltrate. And if we move to higher power, we can see that the infiltrate is mixed. Within this inflammatory infiltrate, there are scattered lymphocytes and a few granulocytes, but by far and away, the most common cell in the infiltrate were these histiocytes. And these histiocytes contain chunky, kind of golden brown pigment within their cytoplasm. They're macrophages that have gobbled up this material. And again, you see it's golden brown. It's the granules are variable in size and shape. And this is much more in keeping with iron than with melanin. Melanin pigment tends to be darker, and there is more uniformity in the size of the granules. So let's back out again with that in mind. And I don't think it would take much imagination for me to convince you, let me get the pencil here, that what happened here, there was a prior shade biopsy. And so you can imagine the surgical device obtaining a shade biopsy this way. The biopsy did show basal cell carcinoma, and so this was a re-excision of basal cell carcinoma. There's no basal cell carcinoma here, but what we do have is a situation in which Monsel's solution was used as the hemostatic agent, and we have a Monsel's tissue reaction here. Monsel tends to produce this yellow-brown pigment within macrophages. It is an iron-containing substance, ferrous subsulfate, and a pearls, rather a Prussian blue or iron stain here, ferrous iron stain pearls would stain this material bright blue. And so this is a Monsel's reaction. Aluminum chloride does not produce as brisk of a inflammatory reaction when it is used. And sometimes Monsel's can produce even a more robust inflammatory infiltrate. It can produce almost a pseudosarcomatous reaction in the skin. So Monsel's reaction, I for sure will be able to recognize this for a core examination. Moving on to slide number 5. Let me tilt the slide again. We have a large punch biopsy in this particular instance, bisected. If we move to higher power, we can see a high concentration of follicular and sebaceous elements, indicating that this specimen was likely from the head or neck. In this particular instance, it was from the face. And again, like the last case, you can see that the epidermis is somewhat thinned with effacement of the reedy ridge pattern. There's a little bit of dermal fibrosis within the underlying papillary dermis. And if we look along the DEJ, we can see there's confluence of pigmented melanocytes along this effaced dermal epidermal junction. There's even some scatter of these melanocytes into the overlying granular and spinous layer. This is a little bit disconcerting. One starts to think about the possibility of melanoma in situ here. However, if we back out, we can see that this proliferation of melanocytes along the dermal epidermal junction is only present above the zone of dermal fibrosis. There's no extension of the melanocytic proliferation in the epidermis beyond the zones of dermal fibrosis. Furthermore, if we look in the dermis beneath the zones of fibrosis, we've got orderly nests, cords, and strands of uniform melanocytes here within the dermis. There's no nuclear hyperchromatism. There's evidence of maturation, no mitotic figures. So we can breathe a little sigh of relief, because this constellation of findings with normal appearing melanocytes beneath the zone of fibrosis and an unusual melanocytic proliferation in the epidermis only above the zone of fibrosis is highly suggestive, if not diagnostic, of a persistent melanocytic nevus. I prefer the term persistent as opposed to recurrent. Certainly, recurrent melanocytic nevus is definitely well entrenched in the literature. In fact, really what clinicians mean when they say recurrent nevus usually is they're seeing recurrent pigment. The nevus obviously never was completely removed. Otherwise, one wouldn't get persistence of the nevus. Sometimes the melanocytes that repopulate the lesion are either outside of the plane of the section, or they may be present in adnexal structures and not detected. A lot of times when we see lesions like this, we'll immediately check our system to see if there was a prior biopsy, because if it's available, you want to compare it to the current sampling to see if indeed there are any changes there. And that's what we did in this case. And this particular slide was not in your slide deck, but one can see that the prior biopsy specimen from the site was a trisected shape biopsy specimen. There's a dome-shaped papule. And if we zoom in and take a look at this lesion, we can see that it's very banal appearing. We've got orderly nest cords and strands of melanocytes present within the dermis. There's evidence of maturation with depth. Not only do the nuclei of the melanocytes get smaller, but the nests tend to break up into cords and strands as we move deeper down into the dermis. So again, this is a persistent or recurrent / residual melanocytic nevus. Let's go ahead and move on to case number 6. Case number 6 was a trisected shape biopsy specimen. The specimen was obtained from volar skin. You can see that the cornified layer is markedly thickened. The epidermis is slightly hyperplastic, and there's an absence of follicular units here. I think I'm going to focus on the bottom piece because we had more of the process represented in the bottom piece. And as we move to higher power, we're beginning to get a sense that we're dealing with a neoplastic process. I'm going to get my pen here. And you can see that we have a fairly well circumscribed neoplasm here in the dermis. It's not encapsulated, but kind of has a benign silhouette, the caveat being, of course, that it's partially transected. This is clearly a mesenchymal tumor. We don't see epithelial structures here. And if we move to higher power, we can see that this lesion is composed of fascicles and or nested aggregates of cells embedded within a somewhat fibrotic stroma. Some of these cells have spindled or fusiform shaped nuclei. A few are characterized by a more epithelioid proliferation, and there are dilated vessels present within this lesion. Cytologically, these cells are fairly benign. The nuclei are somewhat pleomorphic, but none are hyperchromatic, and we're not seeing necrosis or mitotic figures. So architecturally and cytologically, we have a benign neoplasm. This particular proliferation is quite commonly found on acral surfaces. And if we look in areas, and I'm going to look at a couple of sections, we can see that these cells tend to, in areas, form concentric onion skin-like whorls. They almost resemble Pacinian corpuscles. And that configuration is very characteristic of this lesion. This is a cutaneous perineurioma. I'm moving up to the top piece because I think you can appreciate the onion skin-like whirling of the cells in this particular case. Cutaneous perineuriomas are probably more common than most people realize. They're usually 5 millimeters or less in size, flesh-colored, and I think a lot of times the clinical appearance is that of a benign lesion, so they're not biopsied all that often. I think the incidence is probably more common than the literature would indicate. These also are a type of nerve sheath tumor, like the Schwannoma, but rather than being composed of Schwann cells, they're composed of perineural cells. Perineural cells, like arachnoid tissue, are S100 negative, but they are positive with epithelial membrane antigen, EMA. And I've got an EMA stain here to show you. this is an immunohistochemical stain, and one can tell that because it looks kind of like black and white television. In immunohistochemical stains, the epidermis is going to be kind of this blue or blue-gray color, as is most of the tissue. In this particular instance, we use a fluorescein-tagged antibody. This is a brown, not fluorescein, this is a brown chromogen. This is a DAB-tagged antibody. And one can see that the constituent cells are expressing EMA. And so the constellation of findings, location on volar scan and the EMA positivity are very characteristic of a perineurioma. Okay. Let's go ahead and move on to our next case, case 7. And this was a biopsy from the scalp. You can see that there's an adherent piece of epidermis and dermis here, characterized by a fairly high density of terminal follicular units. And these are embedded deeply in the subcutaneous tissue. The density here is fairly characteristic of scalp. And we've got a cystic epithelial neoplasm in these sections, which has a very complex lining. It looks like cyst within cyst. We've got the very characteristic rolls and scrolls here, a pink epithelium. And if we look at the lining of these cystic structures, we can see that they're composed of stratified squamous epithelium. And we've got abrupt keratinization here without interposition of a granular layer, and the production of very homogeneous, tightly packed eosinophilic keratin. This, of course, is tricholemmal keratinization. You see it in tricholemmal cyst or pilar cyst. And in this particular variant of a pilar cyst, we get we get proliferation of the cyst wall. And as the wall proliferates, it tends to turn in on itself and produces these so-called rolls and scrolls. And so we have here a proliferating tricholemmal cyst, also known as a proliferating pilar tumor or a proliferating tricholemmal tumor. These can get quite large, and they are commonly located on the scalp. Occasionally, one can see malignant degeneration within these tumors, and some people refer to that as a tricholemmal or carcinoma or proliferating tricholemmal cystic squamous cell carcinoma. In that particular instance, however, one tends to see striking cytologic atypia with readily identifiable mitotic figures and striking nuclear pleomorphism and or necrosis. So fairly uncommon occurrence, but this is our proliferating tricholemmal cyst. Okay, let's go ahead and move on to our next case, shifting gears here. This is case number 8, and we have a punch biopsy. And present within the dermis, this is a bisected punch biopsy specimen, you can see the epidermis is somewhat hyperplastic, and we have a dense diffuse infiltrate kind of filling the dermis, extending to the edges and to the base of the biopsy specimen. And at this power, it's kind of hard to be certain whether we're dealing with a neoplastic infiltrate or an inflammatory infiltrate. We certainly can't assess much in the way of architectural features. Clearly, this is quite cellular. We're seeing a lot of blue, so that means we're seeing a lot of nuclei here. So we're going to have to move into higher power and see kind of what we're dealing with here. And as we move to higher power, hopefully you were able to appreciate the fact that there are a number of lymphocytes here with small round to oval nuclei. And then there's also a proliferation of histiocytes here. The histiocytes have larger nuclei than the adjacent lymphocytes. They have abundant kind of pink to slightly bluish cytoplasm, and they're forming collections here or small granulomas. So basically we have a granulomatous dermatitis here. And then in areas, let me go down to the other piece, there were actually collections of neutrophils present within the histiocytes here. And you can see the multi-lobated neutrophils here. So basically what we've got here is, here's another one of the microabscesses. We've got suppurative and granulomatous inflammation. Now, the most common cause that we see of suppurative and granulomatous dermatitis in dermatopathology, of course, is a ruptured cyst or a ruptured follicle. However, this is much more robust than one sees typically as a response to a ruptured cyst or follicle. Also, we're not seeing any remnants of cyst here, nor are we seeing cornified cells in the infiltrate. And so the other big category that one needs to think about when one encounters suppurative and granulomatous inflammation like this, of course, is infectious processes and deep fungal infections, sometimes bacterial infections like nocardia or mycobacterial infections can all cause suppurative and granulomatous inflammation in the skin. I will tell you here, and hopefully you didn't spend too much time looking, there were no readily apparent organisms that were present in these H&D stained sections. So in that case, we're relegated to call the clinician and find out about the clinical history. This patient had a few nodules on the arm. And of course, we're going to get PAS, GMS, phyte, and or AFP, and frequently tissuegram stains. And in this particular instance, and again, you didn't have this slide available for review, this was a phyte stain. Phyte stains tend to have this blue counter stain. And if we move into higher power, let's let this kind of settle down for a minute. Hopefully you can appreciate that all of these histiocytes contain innumerable acid-fast organisms. Both the AFP and the phyte stain were positive in this case. So in this instance, we've got a mycobacterial infection, and PCR was subsequently used to speciate the organism, and this proved to be MAI, Mycobacterium avium intercellulare. So this was an atypical mycobacterial infection. Again, you're going to need, in the case of a mycobacterial infection, AFB and or phyte stains to verify the diagnosis. Okay, so just wanted to show you that case. And again, we did use PCR to speciate the organism in this particular case. Okay, let's go ahead and move on to slide number 9. Slide number 9 was a bisected specimen. And as we move to higher power, one can see there's a somewhat nodular infiltrate within the dermis. We've got a small hair follicle here, and we've got this nodular infiltrate extending from the papillary into the upper reticular dermis. The surface of the specimen is gently papillated, and one thing that should catch your eye is the uniformity of the infiltrate. These cells are all similar in appearance, and they're all kind of evenly spaced. And one of the things that one thinks about right away, because these cells are nested, is the possibility of a melanocytic nevus. I mean, that would be topping my list on scan. We've got nest, we've kind of got splaying of the infiltrate between collagen bundles, kind of has some attributes of a congenital melanocytic nevus. If we move to higher power, however, we can see that these cells have round to oval nuclei. They have fairly abundant pale staining cytoplasm, and there is a little bit of granularity to the cytoplasm here. Also, there's not a lot of maturation with depth, and in areas there were a few eosinophils admixed with these cells. And this constellation of features, the fried egg appearance of many of these cells, should lead you to consider the possibility of a mastocytoma. Occasionally, infiltrates like this can also be seen in Langerhans cell histiocytosis. However, in that particular instance, the nuclei are going to look different. One is going to see either notched or grooved or reniform nuclei. And if you take a look here, these nuclei are all round to oval and located in the central portion of the cell. And again, this uniformity of the infiltrate is very characteristic of a mastocytoma or mast cell disease, but it does bear striking similarity to a melanocytic nevus. And in this particular instance, I did include for this presentation the CD117 or c-KIT stain. And if we move to higher power, you can see that this infiltrate is strikingly positive with c-KIT or CD117, confirming that these are indeed mast cells rather than melanocytes. The S100 was negative, and you can see here there's no melanocytes really staining along the DEJ. So this was a mastocytoma. Okay, let's go ahead and move on to slide number 10. Slide number 10 was so let me flip it, a trisected shave biopsy specimen. This is from severely sun-damaged skin. You can see that the epidermis is quite thinned with effacement of the reedy ridge pattern. There's striking solar elastosis evident within the underlying dermis, and the epidermis is quite thinned with effacement of the reedy ridge pattern. If we look along the dermal epidermal junction, one can see that there's confluence of melanocytes present along this largely effaced dermal epidermal junction. In many foci, solitary units of melanocytes predominate over nest, and the nest of melanocytes that are present are not equidistant from one another. And anytime one sees a broad junctional melanocytic lesion on sun-damaged skin, really your starting point should be melanoma in situ. Look at this lone nest over here. This is a Lentigo Maligna type melanoma in situ, or melanoma in situ on severely sun-damaged skin. Frequently, the epidermis is so thinned that one doesn't see appreciable upward scatter or pagetoid scatter of melanocytes along the dermal epidermal junction or within the overlying epidermis. So you need to make sure that you look at the architectural configuration. And again, typically these lesions are quite broad, but the changes can be subtle. There may not be striking cytologic atypia of the melanocytes. These are a little bit pleomorphic, but they're certainly not going to slap you in the face like some highly atypical melanomas. So again, what you want to look for is effacement of the DEJ, a predominance of solitary units, some focally confluent, and irregularly sized and distributed nest along an effaced dermal epidermal junction from severely sun-damaged skin. In this particular instance, I didn't include the immunos. A MART1 stain and SOX10 stain showed more melanocytes than we're seeing here in the H&D stain sections, and these melanocytes were positive with a PRAME immunostain. So this was melanoma in situ from severely sun-damaged skin. Okay, case number 11, rounding the home stretch here, finish out pretty quickly. We've got a trisected shave biopsy specimen. This clearly, even at scanning, one can see is an epithelial neoplasm that's been transected at its base, also extending to the edge. The surface of the specimen is eroded and covered with hemorrhagic scale crust. And obviously, this is dark blue, very high degree of cellularity. So right away, we want to make sure that we look at the cytologic details of this particular proliferation carefully. If we move to higher power, we can see that this is an epithelial proliferation, and it's composed of very pleomorphic hyperchromatic cells. These cells have nuclei that are quite variable in size and shape. This almost has a wind-blown effect. There are clearly identifiable mitotic figures and apoptotic cells. And so you might be thinking, oh, this looks kind of like a Bowen's disease or squamous cell carcinoma in situ. However, there are a couple of features here that you need to know. One, scattered throughout the neoplasm, there's evidence of duct formation. There's ductal differentiation within this tumor. Second of all, take a look at the stroma. This stroma has the edematous vascular tumor that we normally associate with poroid neoplasms or acrosyringio derived neoplasms, acrospinoromas. And so the combination of cytologic atypia, duct formation in the stroma is all evidence pointing to the diagnosis of porocarcinoma in this case. Porocarcinomas are fairly infrequent tumors. We don't see them that often. They typically occur in older individuals. They can occur on the trunk. Lower extremity is a common location as well too. And these are bad actors. The recurrence rate, even after adequate surgical excisions, fairly high, 20 to 30% in most series. So this is an example of a porocarcinoma. And to make the diagnosis of porocarcinoma, you really need to identify ducts here. But it does bear some similarity to squamous cell carcinoma in situ and Bowen's disease. Okay, let's go ahead and move on to our last case. We'll close out case number 12 as an interface dermatitis. And in this particular instance, we have a bisected punch biopsy. This is from the trunk. And as we move to higher power, we begin to see that there's a superficial perivascular infiltrate within the dermis, kind of a basket weave cornified layer. And you can see that the DEJ, the changes here are kind of subtle, but it's not real crisp. There may even be a little spongiosis here. If we look along the DEJ and move in, we begin to detect, however, vacuolar change along the DEJ and numerous dyskeratotic or apoptotic cells within the epidermis. And so right away, you might have been thinking, oh, this looks like pretty good for erythema multiforme. There's basket weave cornified layer, there's vacuolar change, there are necrotic keratinocytes. And I think that clearly is a decent diagnostic consideration. There are some melanophages in the dermis, but in interface dermatitis, if any interface dermatitis, if there's an increased amount of melanin pigment within the basal layer, one can see pigmentary incontinence. However, if we go down and take a look at the infiltrate, you have to look in a few areas. We can see that there are indeed a fair number of lymphocytes, but in some sections, and it may not be this one, there were lots of eosinophils. Yeah, let's go down and take a look at the other piece within the infiltrate. And when we begin to see these changes, vacuolar change, necrotic keratinocytes, and an infiltrate with lymphocytes, pigmentary incontinence, and numerous eosinophils, obviously fixed drug eruption moves much higher on the list. And this was clinically a classic fixed drug eruption. Fixed drug eruption can present with basket weave cornified layer, especially if it's biopsied fairly early in the course. But the key differential with fixed drug eruption typically is erythema multiforme. Both, as this case demonstrates, can have a basket weave cornified layer. What distinguishes them, the changes in the epidermis can be identical, is the presence typically of lymphocytes, eosinophils, and melanophages within a fixed drug eruption, and the presence of lymphocytes only in the setting of erythema multiforme. That being said, sometimes you can get drug-induced EM where you can see a few eosinophils. And in those instances, differential is pretty much based on history and clinical findings. So anyway, hopefully that was a helpful discussion to you. And if you have any questions, please feel free to reach out to me or email the education@SagesDX email. Thank you very much.